Our group is presenting on Pyoderma gangrenosum, which we will refer to as PG moving forward. So first, just a little overview of what it is. It's a rare chronic recurrent skin disorder in which patients get small red bumps or blisters that can grow and join together to become large open sores or ulcers. These ulcers can develop quickly and usually clear up with treatment, but scarring and recurrences are common. It is not infectious or contagious, and you can see here some of the pictures of them. Moving into etiology, the exact causes of PG are unknown, but it does appear to be a disorder of the immune system and is often associated with autoimmune diseases such as ulcerative colitis, Crohn's disease, and arthritis. Additionally, it may have a genetic component, and it can occur after an injury to the skin such as trauma or surgery. And moving into populations, it affects 1 in every 100,000 people in the United States. It's more commonly found in women than men, and more commonly found between the ages of 20 and 50 years old, but it can affect any age. Also, patients with certain underlying conditions such as autoimmune disorders, inflammatory bowel disease, or arthritis are often found to have PG. And lastly, blood disorders such as acute myelogenous leukemia, myelodysplasia, or myeloproliferative disorders.
Okay, the pathophys of PG is not well understood, and there's some literature coming out looking at some different things, but as Sophie talked about, PG is a disorder in which infection, neoplasia, thrombophilia, and other inflammatory conditions are not present, which essentially means that even if you have one of these underlying conditions, these wounds can kind of just appear out of nowhere or get worse from some type of micro trauma. Some recent literature that we were able to find about the pathophys states that it's multifactorial into 3 different areas. Neutrophil dysfunction. So there's this aberrant neutrophil chemotaxis that goes on. So just basically neutrophils are running rampant at random times, causing pathergy, which is kind of just like excess trauma that shouldn't happen to the skin due to an unknown cause. The second part is due to inflammatory mediators. So that cytokine production we learned about is increased, causing more tissue to be destroyed. And then, as Sophie also said, there's sometimes genetic components involved, so they can cause this increased inflammatory response. So here I found 2 nice pictures, just one on the left showing how the genetic predisposition and your dysregulated immune system can play a role. So those neutrophils go through phagocytosis and metabolize the skin more than they should. You can see that there's that increased production of the inflammatory cytokines like IL-6 and IL-8 that continue to bring in more cells to cause this tissue damage. And then also that pathergy phenomenon can be a cause due to some type of genetic component or the immune system. And then again, to the picture to the right, just kind of lists some more stuff that you might be able to dive deeper into about the genes that can be affected, and then also what happens with that neutrophil dysfunction and the type of cytokines being released in inflammation. And the combo of those 3 can cause that wound that you see there. So here I found another good picture for us, just kind of to look at the phase that someone with PG will go through. So, and this might help you in the clinic because it is rare, but if you see it, this might be able to go back and help you. So phase 1, you have this tender, palpable spot that kind of pops up on the skin. You might see those little bumps that we talked about earlier. And then phase 2, this halo occurs with necrotic ulceration, so kind of see a dip in the skin. And then phase 3, the edges of this central ulceration kind of get inflamed, and maybe you can palpate that or notice it. And then phase 4, if it does heal, it will kind of have an atrophic scar formation. So the effects on normal healing. So as you recall from what we learned earlier in the semester, neutrophils are the first to arrive. They help with phagocytosis, and they are cell mediators and playing a key role. So a recall for us, if aberrant neutrophil chemotaxis occurs in PGs, which process do you guys think would be affected in normal healing. So here we'll give you a couple seconds to think about that, and then we'll show you the answer. So hopefully you said the inflammatory hemostasis phase, the first phase. So what we're inferring here is kind of that chronic inflammation is what's going to go, what's going to happen in people with PG due to the creation of new wounds, or if they have a new wound can come on randomly, or if they have a micro trauma, this wound will just stay in this chronic inflammation phase. Some possible reasons could be to the increase in MMPs, which regulate tissue degradation we learned about. This will cause that excessive breakdown of healthy tissue. You cannot move onto the proliferative phase and can cause this endless cycle. So you can get these to heal. We'll learn more about treatment later on, but patients can be stuck in this phase for a long time.
So for medical treatment, early diagnosis is really important for treatment. There aren't actually diagnoses that can rule this in. It's just a bunch of tests that rule out everything else, and this is kind of a last resort. This is what we think it is because there aren't any signs that it is something else. Goals for treatment are to reduce the inflammation. These patients are in a lot of pain most of the time, so controlling their pain, and then as Rich just talked about, improving their wound healing cycle, and then also controlling their underlying condition that is related to this but isn't the reason that their wounds are actually being caused. Just making sure though that that condition is under control. For mild cases, they'll start off with topical agents, so antibiotics and corticosteroids. And then if they need to be a little bit more aggressive, they'll try some immunosuppressive agents. So those are prednisone and cyclosporine, most common. If these do have dressings, which not all the times will they dress these wounds, it's going to be non-adherent and moist. These wounds have some sort of fluid leakage, but not a lot. So you want that dressing to complement that and be kind of in the middle as well. So a little bit wet, but not quite dry for a dressing. So continuing on with medical treatments, a big thing is injury prevention. So just making sure these patients are being careful with things that they are doing outside of the clinic so these wounds do not become bigger or they have skin breakage. And then again, just going back to those pain medications, that's going to be a big part of this, just so the patients aren't in pain, as this is a chronic wound and it does take a long time for it to heal. Another option, which is rare but has been done in some research, is skin grafts, although they do find it difficult to take for wounds like this. And then common referrals are to a dermatologist and also a wound care clinic.
And as it was stated earlier, there are many options for treating PG, but as of right now, there's no gold standard for therapy. The main focus of PT for PG is to reduce systemic inflammation and then also work on pain management for the patient. With PT treatment, you definitely need to take into consideration that it should be personalized. So you should look at the location, number, and size of lesions, the extracutaneous involvement, if there's any underlying systemic diseases that may be impacting this injury. Also, the cost, depending on how long you're going to be treating this or your prognosis, it's definitely important to take into consideration what materials you're using for dressings and other topical agents or medications, and then patient preference, so just building that therapeutic alliance and working with them to get the best outcomes. Also with treatment, sharp debridement should be avoided given the high rate of pathergy with this disorder. Also, a study by Fletcher et al. Found that about 30% of individuals have undergone debridement by a wound care specialist because of diagnostic uncertainty with this condition. It's also important for therapists to work with the patient on typical wound care treatment of lifestyle modification and education. So letting them know and having the discussion about how important nutrition and exercise are for wound healing and how they can help with bringing the right nutrients and blood flow to the area to help with that wound. Also, if they're a smoker, talking about smoking cessation, because we know that smoking can have a big impact on inflammation in the body, which is the main focus of what we're looking at with PT here. And a main intervention used with these patients is compression therapy, because we want to control the edema and promote that optimal environment for wound healing. And can anyone think of what are 2 other possible modalities that we've discussed in class so far that may be beneficial in treating PG? So I'll give you a few seconds to think about that and jot it down, and then we'll reveal the answers. So the first one is that negative pressure wound therapy has been shown to have some promise. And also hyperbaric oxygen has been used in some of the control trials as creating more positive outcomes for these patients.
Prognosis for PG depends on overall health and their systemic condition. And as I talked about before, their risk taking, so just making sure that they aren't creating wounds outside of the clinic by their behaviors. Underlying conditions increase the severity and the recurrence of these wounds in patients. So just making sure that is really under control is the main focus for their medical treatment. This wound can progress very quickly. So through those stages that Rich talked about before, someone can move through those phases very quickly. And sometimes they don't seek help right away because it may not look like something. And then by the time it reaches that phase 4 or that phase 3, it's too late and they already have large wounds on their lower legs. This often can be healed with proper and aggressive treatment, but again, early diagnosis is super important for that. It is common for PG to return or leave scarring. And then if left untreated, so if someone doesn't seek help, this often become infected and then lead to death and caused by sepsis. And then we just have a Kahoot for you guys to do here. Here's the link, and then it'll also be posted in the description for the YouTube video. Let us know if you have any questions, and then here are our references.